chamber, albeit that there is straddling and overriding of the right atrioventricular valve. And this situation across the atrioventricular junction can be described as a concordant or discordant or ambiguous atrioventricular connection, all belonging to the group of hearts with a biventricular atrioventricular connection. In contrast, on this panel here, we have a double inlet atrioventricular connection. Now, what has changed from this situation to this situation? It is the difference in position of the ventricular septum, which is stippled here and here, in relation to the valvar orifice. The difference between this diagram and this one here is that more than 50% of the right-sided atrioventricular valve or right atrioventricular junction connects to this ventricular chamber here, making this ventricular chamber the dominant ventricle and thereby conferring it into a double inlet atrioventricular connection status. Do you follow that? Does that make sense? So the degree of overriding of the atrioventricular valve, or the portion of atrioventricular valve, can affect the type of atrioventricular connection, making it either a univentricular type or a biventricular type of atrioventricular connection. Now let us look at a few specimens to demonstrate the point. We have this heart, which I think you have seen on several occasions before. If we do a 4-chamber section through this, we see very nicely the tricuspid valve is both overriding, referring to the commitment of its orifice, and straddling, referring to the insertion of its tension apparatus. So both overriding and straddling the ventricular septum to become partly committed to the left ventricle. But this heart still has a biventricular atrioventricular connection because the amount of straddling is less than 50% of the tricuspid valve. So we have a malalignment between the atrial septum and ventricular septum, giving you the straddling and overriding situation, but we still have a biventricular atrioventricular connection. Now look at this, another situation here. Again, trying to give a 4-chamber section as near as we can. The right atrium here with the atrial septum, left atrium, and you notice a valve on the left side and another valve on the right side, both entering one ventricular chamber. And by looking at the apical trabecular pattern of this ventricular chamber, both the posterior portion as well as the anterior portion, we can see that it resembles a left ventricular morphology and hence double inlet to a morphologic left ventricle or dominant left ventricle. Putting the heart back in position, we see that on the right anterior surface of the heart, we have another chamber here, which has trabecular pattern of right morphology. It is not so obvious now because we have taken away the front wall of this chamber. Now we can recognize the trabecular pattern as being different from that of the dominant ventricular chamber behind. And we can therefore describe this chamber as a rudimentary right ventricular chamber, which is missing its inlet component. We have no evidence of an atrioventricular valve at all in this chamber, whereas we have found two atrioventricular valves in the left ventricle. So we should be able, judging on the trabecular pattern, to describe this as a ventricular chamber, even though it is missing its inlet portion. What we have is the apical trabecular portion, and in this case also the outlet portion. This small and rudimentary right ventricle communicates with the left ventricle through the ventricular septal defect. So it seems to us illogical to call this type of heart a single ventricle when clearly we have two ventricular chambers in existence, albeit that the rudimentary ventricle is rather smaller than the dominant ventricle. Now the position of the rudimentary ventricle and can vary in these hearts with double inlet left ventricle. In the post-mortem series, we usually find that they are sitting on the right anterior aspect. In the clinical setting, it's more usual to find them sitting on the left anterior shoulder of the ventricle. Here we are. We have the small rudimentary right ventricle again with a ventricular septal defect and outlet up here to the aorta. Open up the heart and we have a double inlet again, two atrioventricular valves into a dominant left ventricular chamber. So there is no need to deny ventricular status to this rudimentary chamber that is sitting on the anterior aspect of the heart. This ventricular chamber can also be sitting on directly anteriorly, as shown on this specimen here. This right on the frontal aspect of the heart, and it can easily be recognized or picked out if you're able to trace the epicardial course of the coronary arteries, because there are usually two coronary arteries delimiting the extent of the rudimentary right ventricular chamber and opening it. In fact, this chamber has two ventricular septal defects communicating with the dominant left ventricle. And opening it, we can see a large common atrial chamber opening through a common atrioventricular valve into a dominant ventricle of left morphology. Notice the very fine apical trabecular pattern. But the common atrial chamber in this heart actually consists of two right atrial appendages. So there is a right isomeric arrangement of the atrial appendages, and we can see the bilateral arrangement of the terminal crest, one here on the left side and the other here on the right side, giving origin to pectinate muscles which go all the way around the back of the atrioventricular junction. In this case, the atrioventricular valve is a common valve guarding the atrioventricular junction. And this brings us to the variability in the in the morphology of the atrioventricular valves that guard the junction. We take a slice through there, through the middle of the heart. You can have a variation of two perforate valves, a common valve as you have seen just now, overriding and straddling of one of the valves, or we can have one perforate and one imperforate valve, but connecting to the same ventricular chamber. Now the rudimentary right ventricle is always in anterosuperior position in relationship to the dominant left ventricle. And we have a rather larger heart this time. And by sectioning it in simulated parasternal long axis view, let's open it up, tearing away the super glue, we can see now the left atrioventricular valve, the right atrioventricular valve, both entering the left morphologic left ventricle, and up here in anterosuperior position is the rudimentary right ventricle communicating through the ventricular septal defect. So a rather classical parasternal long axis section as you see in this type of heart. You notice also that whilst I've got the two separate atrioventricular valves here, there is usually, if you scan towards the back of the left ventricular chamber, you find a prominent muscle ridge down the back between the two atrioventricular valves. And this is the posterior ridge in the left ventricle. This should not be mistaken for the ventricular trabecular septum. It does not extend very far forwards, it's quite limited in its extent. And because of the position of the rudimentary right ventricle, you should also notice that the ventricular septum does not come to the back of the heart. Instead it comes towards the acute margin of the heart in this plane. If I come back to a smaller heart, we can demonstrate this. We see the rudimentary right ventricle here with its ventricular septal defect, and you can see the delimiting arteries, one down here and the other along the acute margin. So you see the ventricular septum coming across the posterior part of it actually comes to the acute margin of the heart when the rudimentary ventricle is right-sided. Open up the heart. At the crux of the heart there is no ventricular septum, but you might spot the posterior ridge sitting in between the two atrioventricular valves. Now the atrioventricular valves also can be associated with malformations apart from being either two discrete valves or imperforate or two perforate or straddling and overriding. It can be dysplastic, or in some cases like this one, the right-sided atrioventricular valve is stenotic or smaller than the left valve. If we look at this heart here, Again, we see a right-sided rudimentary right ventricle, again with the septal, the plane of the septum coming to the acute margin rather than to the crux. Again, a double inlet with both atrioventricular valves to the left ventricle, but have a look at this part of the right atrioventricular valve. It has insertions to the crest of the ventricular septum, so it's partly straddling, but not, it hasn't quite achieved the straddling status yet. It is just, there's just insertion to the crest of the septum, and the ventricular septal defect here widely patent. Also, when you have two discrete atrioventricular valves, you may have anomalies of the tension apparatus as shown in this specimen. They crisscross to insert into a peppery muscle here, so there is a sort of joining together of the tendinous cords. And this is important to realize if you're going to contemplate a ventricular septation procedure for the ventricle. Now we have seen that there is almost always a communication between the left and the right ventricles. The communication can be very widely patent, as in this specimen, or it can be very, very restrictive, as in this specimen, which I can just about barely get the right ventricle open. Extremely hypertrophied probe down the ventricular septal defect there. If we turn the heart around to the dominant ventricle, we see that right around the margins of this ventricular septal defect is a lot of fibrous tissue which is attempting to close it down. Now what happens when you have a restrictive ventricular septal defect? What will happen to the flow that normally goes to the rudimentary right ventricle, assuming it has a great artery coming off it? It will occlude, it will restrict flow to the great artery that is supported by the rudimentary right ventricle. And you may need to enlarge the ventricular septal defect. And then it is important to realize what the margins of the ventricular septal defects are. If you're dealing with, for instance, with this sort of situation, where you have a large ventricular septal defect, then you probably have no problems. But you will also notice that in this heart, the rudimentary right ventricle is supporting the aorta, whereas in this heart, the rudimentary right ventricle is supporting the pulmonary trunk with the aorta coming off the dominant left ventricle. So the situation is either that of discordant ventricular arterial connection in this, or a concordant ventricular arterial connection in this situation. The concordant ventricular arterial connection is less common in hearts with double inlet left ventricle, and it is sometimes described as the Holmes heart. Discordant ventricular arterial connections are more common, but you run into the situation where if I get you another heart which has a smaller ventricular septal defect, and we compare this with the heart with a concordant ventricular arterial connection, we then begin to see the relative distance between the margins of the ventricular septal defect in those with discordant ventricular arterial connection compared with those with a concordant ventricular-arterial connection. When the aorta comes off from the rudimentary right ventricle, the ventricular septal defect is much nearer to the aortic valve than when the pulmonary valve comes off the rudimentary right ventricle. So when you have a concordant ventricular-arterial connection, you have a little bit more muscle tissue that you can resect away to enlarge the ventricular septal defect. The position of the area to be removed is related to the margin of the defect that is furthest away from the acute margin of the heart. This being the acute margin of the heart, this being the area of the defect that can be excavated to make a bigger interventricular communication. And this is because the atrioventricular conduction bundle is going to run in the ventricular septum on this margin of the ventricular septal defect, nearest to the acute margin of the heart, but on the left ventricular septal surface, not on the right ventricular septal surface. So if you can avoid the margin of the defect that is nearest to the acute margin of the heart, you are then safe from traumatizing the atrioventricular conduction system. But bear in mind the type of ventricular arterial connection, because with a concordant ventricular arterial connection, you have less chance of damaging the arterial valve superiorly, whereas with a discordant ventricular arterial connection, the arterial valve, the aortic valve, is very near to the margin of the septal defect. Now coming to the disposition of the atrioventricular conduction system. In hearts with double inlet left ventricle, because the ventricular septum does not reach the cardiac crux, you have an anomalous and anteriorly situated atrioventricular node that is going to connect with the atrioventricular conduction bundle. We have a heart here with one of those situations where the right ventricle is situated directly anteriorly. But it makes no difference. The conduction system runs in a very similar way, whether the ventricle is right-sided or left-sided or directly anterior. We'll open up the right-sided atrium. We see in this case the right atrioventricular valve, the os to the right atrial appendage, the coronary sinus in here. The anomalous atrioventricular node is far from the coronary sinus. You will find it more in the anterior quadrant of the right atrioventricular valve, somewhere in this position. And if we look down into the dominant left ventricle and try and follow the course of the conduction bundle, we see the ventricular septal defect peeping through here. We have an anomalous anterior AV node. The bundle is going to come through and drop down here, going on the left septal aspect of the septum and along there, giving you the left bundle branch and passing forwards to give the right bundle branch. So it is this part of the ventricular septum that you have to be careful of to avoid traumatizing the conduction tissues. Let's see if I can get through to the right ventricle to demonstrate exactly where that part of the ventricular septum we're talking about. Just flip the heart back forwards. It is this margin of the ventricular septal defect across here. So it is the margin of the defect that is nearest to the acute margin and furthest from the obtuse margin. So this margin will carry the conduction bundle. Now this is the setting where the right ventricle is situated directly anteriorly. But if you have the right ventricle situated to the left side, you still have, if you're looking from the aspect of the rudimentary right ventricle, you still have the conduction bundle passing in the margin of the defect, that's the VSD, in the margin of the defect that is nearest to the acute margin of the heart and furthest from the obtuse margin. So what is happening now is that the bundle has a little bit further to go before it reaches down to the ventricular septum. So what it does is it crosses from the anterior atrioventricular node and passes partly across the front of the outflow to the posteriorly situated great artery, which in this case is the pulmonary trunk. So it has to cross a little bit in front of the outflow to the pulmonary trunk to drop down on this margin of the ventricular septal defect. So apart from this difference between the situations of the rudimentary right ventricle affecting the disposition of the conduction tissues, there's really very little between them. Now coming to the situation of ventriculo-arterial connections, you have seen discordant ventricular-arterial connections, concordant ventricular-arterial connections. There are also hearts with other types of ventricular-arterial connections associated with double inlet left ventricle. And we have such a case here, a double inlet left ventricle, no doubt about it there. But this time the rudimentary right ventricle supporting both the pulmonary trunk and the aorta through a huge ventricular septal defect. Now there is double inlet ventricle of other morphologies apart from a left dominant morphology. In this heart, which is rather larger than the ones you've seen, we see a very heavily trabeculated ventricular chamber right in the front of the heart. Right-sided atrioventricular valve and left-sided atrioventricular valve, both coming into this heavily trabeculated ventricular chamber. Now it may be difficult to say, well, what is the morphology of this ventricular chamber? Let's turn the heart round to the back. And I think you don't need a lot of convincing to recognize that this is a rudimentary ventricular chamber of left morphology. It is somewhat smaller than the dominant ventricle, and it also, in this case, receives one papillary muscle from the left atrioventricular valve. So we have also a straddling and overriding of the left atrioventricular valve across a very large ventricular septal defect, but double inlet to a dominant right ventricular chamber. And double inlet right ventricles are fairly frequently associated with double outlet from the same dominant ventricle. Double inlet right ventricle can be associated, as in this case, with usual atrial arrangement, or it can exist with mirror image atrial arrangement or with atrial isomerism. In this heart, we have a left atrial appendage on the right side and a right atrial appendage on the left side. There has been Fontan type of repair. We look down the left atrioventricular valve. We see the rudimentary left ventricle in posterior inferior position, but receiving part of the left atrioventricular valve. Most of it goes through the ventricular septal defect to this dominant right ventricular chamber, a very, very hypertrophied chamber, which receives more than 1.5 atrioventricular valves. Now the rudimentary left ventricle in hearts with double inlet right ventricle is situated posterior inferiorly in the ventricular mass, usually in left posterior position and occasionally in right posterior position. In some cases, it may be very difficult to find the rudimentary left ventricular chamber, especially when there's an intact ventricular septum. And this may necessitate doing histological sections through to find the rudimentary left ventricle. But because the ventricular septum is in this heart with double inlet double inlet right ventricle, comes to the crux of the heart, actually comes obliquely downwards to meet up with the crux of the heart at its posterior extent, it's reasonable to expect that the atrioventricular conduction nexus would run in the usual fashion as with hearts with, for instance, an isolated ventricular septal defect. So we can expect a posteriorly situated atrioventricular conduction nexus. Now the final variant of double inlet ventricle is that of a solitary and indeterminate ventricular chamber, as shown in this heart. When we go through it sequentially, we find that it has usual atrial arrangement, the right atrium on the right side, left atrium on the left side, and do a simulated 4-chamber section, but we end up with 3 chambers instead of 4. See right atrium, left atrium with two discrete atrioventricular valves entering the same ventricular chamber. You may say, what is this? Is this not a ventricular septum? Well, this is the posterior ridge that you have seen before, previously when I showed you the situation with double inlet left ventricle. Because if we follow the heart through its frontal section, we don't see the extension of this ridge forwards to form a ventricular septum. And furthermore, the trabeculations are coarser and heavier than that you find in a morphologic right ventricle. You will notice that we have made multiple cuts and sections through this heart to see if there is a second ventricular chamber where there isn't one, and there is no hint of delimiting arteries either. So this is the true situation of double inlet to a solitary ventricle of indeterminate morphology. In these hearts, the atrioventricular conduction system has not been studied extensively. There's only been a couple of cases where serious sections have been done. But they take origin from the atrioventricular junction and either descend directly down to the ventricular myocardium or else follows a prominent ventricular trabeculation. So it's unpredictable which way it is going to run. So in summary, we have defined what we mean by a double inlet ventricle. It is merely the way the heart is connected across the atrioventricular junction. It can occur with various combinations of atrial arrangement, and it can occur with the three different variants of dominant ventricular morphology. So we can forget about single ventricle with infundibular chamber, primitive ventricle, univentricular heart, common ventricle, etc., etc. If we analyze the heart sequentially, and when we come to the atrioventricular junction, we need only to describe the univentricular atrioventricular connection. So I hope you follow that argument. We can forget about primitive ventricle. Thank you.